Sounds good. All right, so good afternoon, everyone. Some of you may be a little bit earlier than noon. My name is Jamie Michael, and I am staff for the NALBOH office, and I will be your moderator today for today's program. Welcome to the webinar, Evidence for Action, a resource for local boards of health, a presentation sponsored by the National Association of Local Boards of Health, or NALBOH. I have just a few housekeeping points before we get started. To help maintain the clarity of the audio presentation, all attendee lines have been muted. If you are having problems with the system, please contact the NALBOH office at 920-560-5644. We will be stopping for Q&A at the end of the presentation. Questions may be submitted by using the question box located at the right hand of the screen. Please type your questions in here. We will answer as many questions as time will allow. Today's presentation is being recorded and will be available on the NALBOH website approximately 1 week from today, and also included in the monthly e-news. An evaluation survey will be sent by email at the conclusion of this webinar, and we would appreciate if all participants would please complete this evaluation so that we can continue to improve future webinar offerings. So with those short announcements, that concludes our housekeeping announcements. Now a little about today's program. Evidence for Action, or E4A, a national program of the Robert Wood Johnson Foundation, supports rigorous research evaluating health and other outcomes of local, state, and national policies, programs, and interventions to determine what is most effective in improving population health, well-being, and health equity. E4A's Deputy Director, Erin Hagan, will share information about their funding opportunities as well as the sort of evidence the program may offer to inform decision-making in your communities. Following Dr. Hagan, one of E4A's grantees, Dr. Stephanie Farquhar, will speak about her funded project that involves a partnership between the Seattle Housing Authority and the Public Health Seattle and King County. Erin Hagan, PhD, MBA, Deputy Director. Dr. Hagan is responsible for the day-to-day operations of the program, including managing the proposal submission and review process, and providing assistance to applicants and grantees. Over the course of her career, Dr. Hagan has worked across a variety of sectors, including nonprofit, academic, and public. She brings experience in health equity, public policy, and evaluation. Prior to joining the National Program Office, Dr. Hagan was the Policy and Government Affairs Manager for the San Francisco Public Utilities Commission. She also previously worked with PolicyLink, a national social and economic equity advocacy organization. Dr. Stephanie Ann Farquhar is a Senior Social Research Scientist at Public Health Seattle King County Health Department and an affiliate professor at University of Washington School of Public Health, Department of Health Services. She draws from the principles of community-based participatory research to address issues of social and environmental equity and teaches courses on policy, ethics, and foundational public health practice. We are very excited to have Erin and Stephanie as our presenters today. Welcome, Erin. The floor is yours. All right. Turn it over to you, Erin.
Great. Thanks so much, Jamie. We are really happy to be able to be here and speak with your members today. Thank you for providing us this venue. So as you mentioned, Evidence for Action is a funding program. It's a national program of the Robert Wood Johnson Foundation. And we fund rigorously designed research, quantitative, qualitative, or mixed methods that expands the evidence base to support the Robert Wood Johnson Foundation's vision of building a culture of health across the United States. So our mission is to support research that yields convincing findings regarding the population health, well-being, and equity impacts of specific policies, programs, and partnerships. And I think it's really relevant, our program is really relevant to the members of NALBOH for a couple of reasons. Both on the front end of our research program, we hope that local boards of health are able to share this opportunity, this funding opportunity, with local health departments and other local government entities who might be engaged in innovative interventions and could use funding to support the evaluation of those strategies. Additionally, we think that Evidence for Action will serve as a source of high-quality evidence to help boards of health and local health departments make evidence-based decisions about the sorts of strategies to advance in their communities. So we really hope that you'll view us in both of these ways, both as a source of funding and as a source of information. So I want to focus today really on the funding program, what sort of research is a good fit for Evidence for Action, some of the high-level criteria for the program itself, and then I will turn it over to Stephanie to talk more about her research specifically and offer an example about, as an example of the type of research that we fund. So Evidence for Action is an ongoing, rolling application-based investigator-initiated program, meaning that we don't have a research agenda and we do not have a specific budget requirement, and we're always open and accepting applications, which makes us a great fit for evaluating natural experiments or ongoing evaluation of public health strategies. So we want to fund research that will aid practitioners and policymakers, so that would be you, local boards of health, in setting priorities and allocating resource. And so we primarily target research that is directly testing the impact of some intervention on health outcomes. You may be looking at other outcomes beyond health, and in fact, the intervention itself may be designed to impact other outcomes more directly, such as financial security or education or literacy. But we want to see how those interventions also may be improving population health outcomes. So when we consider whether research is a good fit for Evidence for Action, the following criteria are our focus. Rigor of the research means that there's a presence of a clear data-driven research question designed in such a manner that either positive or null findings will provide useful information, and that there's inclusion of an appropriate comparison group. The actionability means that results can be used in the near term to inform priorities and decisions. And generally, that research results in the ability to take some sort of action. So research that solely yields the need for additional research is not a good fit for Evidence for Action. Or research that is describing the existence of some sort of disparity or the conditions in a community. So we're really looking for evidence that allows decisions to be informed. The relevance is in relation to clarity and importance of the research aims, hypothesis, and the study population to the broader culture of health framework and goals. And the contribution of the evidence base is relatively straightforward in that the research has the potential to address key knowledge gaps and contribute to scientific advancement. As I mentioned, outcomes must include health as a measure of the effectiveness of the intervention, although we do allow a diverse dimension of other outcomes, and health is defined broadly to include physical health, mental health, behaviors known to influence health. Healthcare access alone is not considered a sufficient outcome for our research, but it certainly might be considered among the outcomes that could be eligible. And then finally, we consider the feasibility, which relates to the qualifications of the team to carry out the proposed research and the appropriateness of the budget and the project timeline. So we don't require traditional principal investigators, but we do require that the team have the capacity to conduct the research. So as I mentioned previously, we do not have a project budget limit. To date, we've awarded projects as small as $46,000 and as large actually as just over $700,000. The range of awards is typically in this range that you see on the slide, from $50,000 to $500,000. So just noting that the $700,000 award is a relatively large award in terms of the funding capacity of Evidence for Action. But you can see that it's quite a wide range, and so what we're really looking for is just the appropriateness of the budget for the project that's being undertaken. We don't require matching funds, but leveraging existing funding is often a good way for us as a program to make a greater contribution with our funding. And our budget ranges are not necessarily indicative of the scope of the research project. So if you visit our website, there are summaries of all of the research that we've funded to date. And a $500,000 grant does not necessarily indicate that the research project itself is more substantial than a grant of $200,000. It often just represents the proportion of research that's being funded by the Evidence for Action program. So sometimes larger budgets are associated with projects in which we are providing the full funding for an evaluation, but smaller budgets may be equally likely to represent a fully robust research agenda, but are serving as an add-on or piggyback funding for an otherwise very large project that has additional funding. So, for example, we have funded a worksite wellness study in Chicago where our funding contributes about $200,000 to an otherwise multi-million-dollar National Institutes of Health randomized controlled trial. While there is no official cap for an allowable budget, our decision-making process does weigh the amount of funding requested against the potential value of proposed research gains, and so larger budgets do face some additional scrutiny. So I want to turn now and give you some examples of the type of research that we've funded to date. I will touch relatively at a high level on these projects, while Stephanie will go into more detail about her work specifically. And as I mentioned, these projects, as well as others that we've funded, have additional information available on our website. To date, we've funded 21 studies and will continue to fund studies on a rolling basis into the foreseeable future. So this first study on the slide is Breaking Down Barriers to Preventive Care, the Impact of Prenatal Care Expansion to Immigrant Women in Oregon. And the team itself is based at Stanford University, and they're examining the causal effect of access to prenatal care for immigrant women on maternal and infant health outcomes and state economic impacts. So the study is taking place in Oregon. The team is based at Stanford. The Water Policy Project team from the University of California, Riverside is assessing whether there is a causal effect of adverse weather events on indicators of population health and if water policy affects the strength of the links between adverse weather conditions and health. This worksite wellness intervention at public schools is a research team from the RAND Corporation, but is taking place in Tennessee, and the team is leveraging existing data from an urban public school system there to determine if locating a health clinic on site at a school and managing chronic conditions through that clinic improves teacher health, retention, and productivity, and subsequently student academic outcomes. The Criminal Justice System research team is from Duke University, and they are examining how parents' interactions with the criminal justice system affects children's health and well-being outcomes in North Carolina. The next study represents the Dallas County Food Insecurity Project. The team is at the University of Texas Southwestern Medical Center, and they are evaluating an ongoing large-scale natural experiment of a shift in charitable food distribution to a community-based model. And finally, our last example here is the Firearm Culture Research Team from Boston University. They're defining gun culture and developing methods by which to measure and analyze its effect on gun violence. They're expanding a multi-state level database on gun ownership, firearm policy, firearm mortality, and examining the interrelationship among these factors and gun culture. A couple of points to point out about these research projects is that often we can serve as a source of funding for projects that might otherwise not be able to find funding either due to federal regulations or or scrutiny in other funding sources. So a couple of examples you see here, of course, are the gun violence study that we have funded, which, as many people know, has a prohibition against funding from federal sources, also funding around immigration, and further, we could provide funding around substance abuse, which often faces scrutiny at the federal level as well. So we pride ourselves in being able to fund needed research on critical public health issues that may not otherwise be able to secure research funding. So with that, I want to turn it over to Stephanie to give more detail about your specific project in Seattle.
Yeah, thank you, Erin, and thank you, NALBOH, for organizing us. I really want to acknowledge and appreciate Robert Wood Johnson Foundation, their staff, and program officers. They, as Erin noted, some of these projects are a bit out of the box and would otherwise have some challenges in getting the support that they need. And Robert Wood Johnson Foundation has provided Seattle and King County with an opportunity to conduct something of a natural experiment based on redevelopment efforts that are happening here in downtown Seattle, and to learn more about the connection between urban community development and health. I want to make sure everyone can hear me fine. Anyone who's not muted?
Yep, you are great, Stephanie.
Great, great. Okay. So something that we needed here in Seattle and King County, and our health department represents both Seattle as the city and then King County as the broader county. We needed evidence based on the fast growth rate of and changing demographics of city and King County. We needed evidence about our community development strategies. Do they work? Do they not work? Who benefits most? I think the benefits of community redevelopment and reinvigoration is something that's assumed. We assumed that it's good for everyone, but we really need to understand more about how residents perceive redevelopment and these types of changes and shifts in their cities and neighborhoods. We need to learn more about temporary displacement that usually accompanies redevelopment, including relocation, and then also learn more about the shifts in resident demographics that seem to be an inevitable part of urban redevelopment. There. So I understand that some of you on this webinar might be interested in learning more about how this opportunity came to be and then how we developed a proposal that was positively reviewed. And I would have to say that one of the factors that really allowed us to move swiftly in submitting a project to Robert Wood Johnson Foundation is that was both meaningful and competitive, is that we had a number of partnerships between Public Health Seattle King County, the Seattle Housing Authority, Neighbor Care Health, Seattle University, Mercy Housing, and other organizations and agencies that we're working with. We had a working history among and between some of those groups, and we really had a shared vision of what it was we wanted to learn, and then a sense of urgency that we need to learn it now because the redevelopment started in 2013 and will continue into 2020. In addition, the Robert Wood Johnson staff and leaders made themselves very, very available to us. We started talking about initial ideas, and then once reviewed, they helped us refine our methods and think a little bit about our scope of work. So I strongly suggest that if you have ideas for a project, you scratch something out on paper that all of your partners can agree to, and then schedule a phone call with a grants officer or another contact at RWJF. It's really time well spent. For example, they helped us think through which data sets will yield the most sort of credible, powerful results that we can then apply to inform community redevelopment. And you'll get a sense of whether or not you're on the right track and being responsive to some of the points that Erin just outlined. To the second point on this slide, the redevelopment process was quite comprehensive. So we were doing more than providing additional affordable housing, but we were incorporating green building practices to develop our affordable housing. We added on-site clinics in the nearby elementary school, for on-site community health workers at Yesler Terrace. We added activities for kindergarten readiness and an employment opportunity training program, and physical space and green space, walking space to encourage community interaction among residents. So this is Yesler Terrace as a neighborhood. It's very unique in that it's a 30-acre site, so quite a small physical space, but a 30-acre site near downtown Seattle that was developed by Seattle Housing Authority in the early 1940s. And it has a very rich history in that it's the city's first publicly subsidized and racially integrated housing. And it became clear that with aging housing units from the 1940s that desperately needed to be replaced, this provided a chance to create something more sort of holistic and comprehensive beyond just new construction. So in 2013, after a great deal of input from residents and city planners and so forth, the revitalization of Yesler Terrace began. One thing to note is that in addition to requiring one-for-one replacement of the affordable housing units, which number in 561 housing units, they're also adding office space, retail space, and very importantly, market rate housing for those who are able to pay market rate. They wouldn't necessarily, or they would not be Seattle Housing Authority residents per se, but you can see some of the complexities that enter when a previously strictly affordable housing community then becomes a more integrated opportunities for diverse types of housing. So our three primary questions had to do with what and who and how much did redevelopment impact. And so the first question here is, what is the combined impact of redevelopment on health and well-being? I'll tell you how we measured health and well-being. What is the combined impact of redevelopment on other community level outcomes such as income, safety, and community cohesion? And then who is more likely to benefit from these strategies? One thing to note is we're not trying to attribute changes to individual redevelopment programs, but rather the combined impact of all of the changes that I mentioned on the previous slide that are happening. And then one additional question that the team wanted to address, and I'm sure many of you see this in your own communities, is how have the demographics at Yesler Terrace changed from 2012 to 2018? Has redevelopment shaped who lives there, who relocated, who returned, the face of community, so to speak? So apologies for this tabular layout, but these are some of the outcomes that we're most interested in, and then our the corresponding data sources. You can see across the top, we're looking at Medicaid claims data, Seattle Housing Authority administrative data, which includes information about the residents, their relocation, income, and a variety of demographic variables. Whether or not they participated in employment education. We have education data from the school that most of the children from Yesler Terrace attend. We have an annual resident survey, and then we have police, crime, and 911 data. So one thing to think about is, of these data sources, what is readily available in your own jurisdictions, and what questions regarding community change could you answer if you were to pull in various sources into one study? And one of the most unique opportunities here is the chance to look across multiple data sources, including some qualitative data work with the residents themselves, and to try to see whether or not there's agreement or disagreement across the different sources. For example, one of the primary interests or outcomes that the residents are interested in is looking at crime and perception of safety. So we have police department data that suggests crime has decreased, but the resident survey data suggests that perception of safety has decreased as well, so it isn't as strong. So why is this? So the opportunity to link individuals across data sources, for example, to look at an individual who lives within Seattle Housing Authority housing and their claims data is an important opportunity in addition to all of the kind of contextual level variables that we have on the neighborhood. I'm not going to linger too long here, I promise, but I think that even though this conceptual model is still a work in progress, one compelling reason to develop a conceptual model, especially from the perspective of a board of health or a health department, is to demonstrate to your constituents and to those who are making decisions about what will be funded and supported in your communities, demonstrate how many different conditions are potentially directly connected to health and well-being. So I always suggest that public health researchers and practitioners, if they're seeking the support of their board of health or city council or county commissioners, they really need to connect the dots between their work and what they're proposing and health outcomes in a clear way. And this helped us present our argument, I think, in a more convincing and clear way to our own health department here. So because one of the primary goals of this project was to link data sources across sectors, we were required to develop and get approved a data sharing agreement. And honestly, this is an incredibly burdensome process to try to get claims data and Seattle Housing Authority data and to get the multiple government agencies that are collaborating on this project together to have agreement that we can share data. So one thought that I have had in proposing this project is, do we follow a lengthy and potentially bureaucratic process to obtain the data that could actually tell us a great deal at a record level or individual level? Or if that's not feasible, thinking about other data sources and the relative ease of getting crime data, for example, where the city of Seattle has an online portal where crime data can be downloaded, and I know that this is sort of a national movement, so I assume that some of you on the phone also have access to open source data that will be less time-consuming to retrieve. So one of the things that we have been able to accomplish with this project, and as I said, it's Robert Wood Johnson funding has enabled us to spend the time necessary to get data sharing agreements across government agencies and to look at redevelopment in such a complex way. I mean, we have 6 or 7 different data sources that we're using. And so this is an example of what you can do with cross-agency data. We are able to get data on all of our Seattle Housing Authority residents. We know where they live and when they relocate and how long they've been in their unit. And then we can look at the 911 call data experienced in their neighborhood and compare it to areas where there are scattered subsidized housing sites and look at Seattle statistics more generally, and then link the rates and types of injury to what it is the Seattle Housing Authority residents are saying they're experiencing. And again, this is just to highlight the level of complexity of the types of projects that Robert Wood Johnson is able to support, in part because they've expanded the definition of health to include many different conditions and stressors that we don't typically see in many public health funded projects. Okay. Additionally, we were, in addition to looking at the crime data and the Seattle Housing Authority data on the residents, we conduct an annual resident survey with Yesler Terrace residents, and we are able to compare, again, crime data to injury data and the Medicaid claims data to this perception of safety and social cohesion. We found that among primarily East African residents from Ethiopia, Somalia, and Eritrea, they perceived safety to be much higher than compared to other groups. So right now where we're at in the project is we're putting together all of these various pieces, and we'll be taking back what it is we're seeing, the types of trends that we're seeing in the data and the themes that we're picking up on. We'll take them to the Yesler Terrace residents and solicit their feedback and input for next steps and ideas about how best to apply this information to inform redevelopment practices in Seattle. So I wanted to acknowledge that this is a solid team that participates in this work, and it includes members of, as I mentioned before, Neighbor Care and Harborview, our medical center and health clinics, John Forsyth and Maria Ursua, who are from the Seattle Housing Authority, and a number of us at the Public Health Department. And I highlight just a few aspects of this project and what we are able to do so far to emphasize that it does take resources and dedicated time to answer the difficult questions, and the rapid pace of population growth in areas such as King County's and maybe in your own raises critical concerns about equity and redevelopment that need to be developed now and need to be addressed again in real time as the redevelopment is taking place. And the support for this project came from our Director of Public Health, Patty Hayes, who provides reports to our Board of Health, but it also required support from the chief medical officer at Neighbor Care, for example, and the executive director of Seattle Housing Authority. So getting that support and finding those champions as you're developing ideas for proposals is really key, and will sort of expedite the process of applying for funds such as this. So that is me and John Forsyth at Seattle Housing Authority. And if anyone on this call would like to explore what it means to pursue RWJ funding from the perspective of a health department or of a health authority, I'm happy to answer any questions now or offline. Thank you.
Great. Thank you, Stephanie and Erin. So at this time, we will stop for questions and answers. If anyone has anything, they are welcome to add them in the chat box. It may be a lot of information at once, and maybe everyone's wheels are turning about what to potentially do with evidence for action, so we can always follow up afterwards. But again, if anyone has any questions, please enter them in the chat box at this time. Looks like Margaret is typing.
So Jamie, while people are typing, I might just add that Evidence for Action is exclusively a research funding program, and so often, having come from the practitioner and advocacy side, we often hear from people, we don't need more research, we just need to act. And actually, I would say Evidence for Action agrees with that statement, and in fact, it's well aligned with our priority of funding evaluations of interventions. And so we do think that there's enough research to act, but we encourage people to evaluate their actions while they're doing so. And so we talk about Evidence for Action in terms of evaluate while acting and informing future action. So hopefully that encourages people to continue doing their good work. And also, we know that sometimes implementation is funded without evaluation, and so we hope to be able to serve as a source for funding for rigorous evaluation while communities, states, and other partners are intervening.
So again, if anyone has any questions, you can enter them in the chat box. Otherwise, I'm going to put up the contact information and additional resources as well to be able to take a look at, and that we can do and follow up as well. Looks like Margaret is typing.
And as Stephanie mentioned and shared her contact information, obviously there are a variety of ways to get in touch with the Evidence for Action Program Office. We do have frequent conversations, both individual, virtual, group conversations with people about their research, the projects that are underway, our funding opportunity, and so encourage you all to reach out to us if you're interested in learning more. As I also previously mentioned, there's quite a bit of information on our website, the call for proposals, grant summaries, et cetera, and encourage you to be in touch if you are interested in learning more.
Well, that's great. And again, we just want to thank you, both Erin and Stephanie, for your time to share the resources. With some of our folks, it may be a brand new concept, which is very exciting to think about what can be done with the project. So again, just want to thank you both. Please watch for announcements about further NALBOH webinars on our website. We kindly ask that you complete the webinar evaluation that you will receive by email shortly following the webinar. And exciting news as of today, the 2017 annual conference registration is now open for Cleveland, Ohio, August 2nd to 4th. So we would ask that you please consider registering for the conference, as it just opened as of today. So again, thank you all for joining us, and we look forward to talking with you again. Well, hold on, we have one question from Margaret, just real quickly. Are there examples of rural small local health departments working with community partners, and small meaning less than 75,000 or so? We just want to answer that question, either Erin or Stephanie, probably more Erin.
Sure. So I will say that of the projects that we have funded so far, we have not funded any projects in rural communities, although we really would like to be able to do so. And actually, the primary reason that we haven't funded many is we actually just haven't seen many applications from rural communities. So we'd love your all's help in getting the word out to smaller cities, towns, rural communities, in the existence of the program and the availability of funding. Personally, I'm from a very small rural community in the Midwest, and so I know that there is lots of interesting, exciting, and different work than what you see in the urban settings going on in the rural communities, and so really are very interested in funding research in those spaces, and are working to do a better job of getting the word out, building partnerships with organizations that work with rural communities, and would greatly appreciate your assistance in doing that.
All right. Well, thank you very much for that question, Margaret, and for the answer, Erin. So again, thank you all for joining us. And if you have any questions, please feel free to follow up with Erin or Stephanie regarding the specifics. Otherwise, we can do our best to help as well. But again, thank you for attending today, and we will talk with you all soon.
Thanks so much for the opportunity, Jamie.
Yep, you're welcome. Thank you very much. Have a wonderful afternoon.